Welcome, everybody, to our third of the summer webinar series on costly diseases and innovative solutions focused on the cost of drugs that we all experience in our day-to-day lives, whether we're just feeling normal and have a slight need for a drug, or if we are facing the serious issues of a specialty drug or a high-cost drug. Today we're going to go through an analysis that we hope that you'll find beneficial, and then we're going to hopefully give you some solutions that Curus has developed. On our program today, other than myself, I'm Mark Schlussel, the CEO of Curus. We have Sarah Amaral, our Chief Medical Engagement Officer, and Sarah has an extensive background in the management of healthcare, not just for us, but in her prior careers of managing private practices, and is highly experienced. So you'll find her very, very helpful. And Jared Mort, who's a retired lieutenant colonel in the Air Force, who served in Afghanistan as the lead officer at a field hospital on the border of Pakistan. And he has lots of experiences that he brought from his military career of over 20 years to Curus to make us a better company. My background is as a healthcare lawyer and as an individual who ran a division of one of the larger healthcare systems in our city for a few years as part of my growth and development in the healthcare area. I'd like to now turn this over to Jared Mort, who's going to begin to take you through our presentation. Jared?
So thank you, Mark. Appreciate the kudos. And what we're going to talk about on our third part of our summer webinar series is the different costly diseases for insurance companies, especially the self-insured. And then at the end, give you some more innovative solutions, very similar to what we've already talked about in the prior two webinars. So part of what Curus does best is we help reduce costs and guide patients through these costly diseases. So we've already talked about cancer treatment, which was last month's webinar. So if you didn't get a chance to view that, please go to our YouTube page or curushealth.com and go ahead and take a look at those. But so we're going to move forward with the other 4 disease states that we cover as well and help companies save money. So we're going to talk about immunotherapy, the 2 most heavy hitting drugs for that, why we give those drugs, and roughly how much they cost. And then we're going to talk about autoimmune with the same discussion, 2 drugs. Then we'll talk about dialysis, and this one's a little bit different, a horse of a different color. And then we're going to talk about hemophilia with 2 of the most common drugs that are given for hemophilia A and how we can manage that. Then once we cover those, we're going to go over some innovative solutions to help drive down costs and improve healthcare. So with that said, I'm going to turn it over. Sarah and I are going to kind of play ping pong here. So she's going to talk about the disease states, the drugs, and how they work and why, and how they're given. And then I'll talk about pricing. So Sarah, it's all you. Let's talk about immunotherapy.
Thanks, Jared, and thanks, Mark. So the first category is immunotherapy medications. Immunotherapy is a new way, it's not probably new anymore, but I think when most people think of a diagnosis of cancer, their first thought is chemotherapy. And this is another way to go about treating cancer. So there's 2 medications listed here. The first one works, it's called Keytruda. Works to block this PD-1, and this helps fight certain cancers, including melanoma, advanced non-small cell lung cancer, Hodgkin's lymphoma, and some other cancers. The way it works is by blocking the PD-1 pathway, and this allows T cells to respond and then attack cancer cells. And the second medication is used for bladder and lung cancer, especially non-small cell lung cancer. Works in a very similar way as Keytruda. It blocks the interaction of the PD-1 pathway and releases the inhibition of the immune responses. So it keeps our body's natural instinct to the immune system to fight the cancer there is the PD-1 pathway in cancer works erroneously to block that inhibition instead of letting. So this medication is helpful for that. The costs, though, as you can see, Jared will highlight those for you, are quite high.
Yeah, great job, Sarah. Excellent explanation there. So even let's go to Keytruda. Everybody's seen the commercials for Keytruda, and you know, you look at that, over $2,200 per dose, and they get a minimum of 12 a year. And the way most of these drugs work is they work either in certain cycles, or depending upon the type of cancer, they may actually be given until the disease is done or over and they're in remission. So that adds up very quickly, tens of thousands of dollars a year. And, you know, so this is one of those drugs that we'll talk about later with our innovative solutions on how we can help the employer and the self-insurer companies bring those prices considerably down.
So, Jared, let me ask you a question. Why do doctors choose immunotherapy versus chemotherapy? Are there reasons for this? Do they get less nausea? Do the people feel better? Is it a better solution and a more effective solution? I'm just curious to understand why doctors choose certain drugs and not others.
Absolutely. That is a great question, Mark. And the answer is a little convoluted, but let me try to make it very simple. Most of the patients will still receive some sort of chemobiotherapy, and these immunotherapy drugs work in concert with the already researched and approved chemotherapy drugs. And then not only that, but these drugs can be given far beyond when chemo stops and continue to help the body fight cancer. Chemotherapy kills roughly, I know this is kind of layman, but chemotherapy kills all the active cells in the body. Okay, any cells that proliferate or divide and reproduce on their own. What these do is they don't work that way. They help the body build up a stronger immune system and fight the exact cells that need to be fought instead of everything in your body. So these are an adjunct to chemo, but most of the time they are given together. However, the research is showing that this on top of chemotherapy and biotherapy, they have much better results. So great question, Mark.
So there would be less toxicity then, because if it's what chemotherapy does is attack the cells that are, any cells, as Jared said, any cells that are dividing more rapidly. So you can imagine that's why you see the side effects of nausea, because the cells in the GI system are more likely to be multiplying. And then the same thing with hair. Your hair is growing, so you have those follicles are multiplying more rapidly, you lose your hair. So you would have fewer side effects, I think. But they are, like Jared said, they're used in conjunction. It's not an either
So this is like a balancing drug. It helps fight the cancer, but it helps the patient in a different way.
Yeah.
Thanks.
Okay. So Sarah, we're going to move on from immunotherapy to autoimmune therapy. Let's talk about that.
So we have just a couple of drugs listed here, medications in the autoimmune category. The first thing I want to do is just make sure that everybody understands what autoimmune disease is. This is a disease that occurs in the body's immune system. What it happens when the body's immune system falsely detects and attacks a threat within the body that doesn't really exist. Even today, experts are not sure exactly what causes autoimmune disease, but tumor necrosis factor alpha, that's TNF alpha, appears to be a major contributor. So you'll see that come up with these medications, that's going to be something where we work to block. The first one is Humira. The second one's Xeljanz. These are both names that everyone has heard. As Jared and I were saying, we're so sick of these commercials. You hear them all the time. Humira is used to treat several different autoimmune diseases, including rheumatoid arthritis, plaque psoriasis, and psoriatic arthritis. It also treats Crohn's, ulcerative colitis, and ankylosing spondylitis, which is a disease that is common in young men that causes fusion of the vertebrae. And so these are diseases that are quite debilitating. This is medication that's been very effective to treat them. The way it works is that this TNF alpha, it triggers inflammation when the body is under threat. So the immune system goes into action to protect it. However, when you have too much of the TNF alpha, that can attack healthy tissue and cause inflammation. Inflammation then leads to pain. What Humira does is bind to that TNF alpha, blocks its inflammatory effect. This reduces the pain and the inflammation in people with autoimmune diseases. And then the Xeljanz, that is used to, there's some overlap here. It's also used to treat rheumatoid arthritis, ulcerative colitis, and psoriatic arthritis. This works in a slightly different way. It's a JAK inhibitor. JAK is an intracellular enzyme, and what it does is inhibit that enzyme, which would otherwise signal to the cells that contribute to inflammation. And that's a pretty layman's, that's broken down. It's probably oversimplifying, but I think you probably get the idea that those are how those work. And they come again with a significant price tag.
How do doctors make a decision as to which of these drugs they use for the autoimmune disease? Because you mentioned a number of diseases that, to me as a layman, I would think are in very different categories, but you've just told us that they're really similar.
So because they're all autoimmune diseases, I think they can all be treated in a similar way, because it's all about this misfiring of the immune system. The immune system, for reasons that are still unknown, all of a sudden recognizes the body as the something to attack. So you're attacking your own immune system.
Yep.
So arthritis and Crohn's are really in the same category.
They're all both autoimmune diseases. Yes.
Yep.
Both
And also like fibromyalgia, one that's like usually the last thing that's diagnosed because they can't rule anything in or out.
Yeah.
And the latest research study I read that was released last October, it was published in the New England Journal of Medicine. They were talking about autoimmune diseases starting later in life, which typically most of them do. And the reason why they were thinking has to do with the introduction of certain viruses like West Nile, Lyme disease, certain other bacterial and viral infections. And also, like Sarah alluded to at the very beginning, the TNF, the tumor necrosis factor, after treating cancer for the first round of chemo, these people are like 100 times more likely to come under an autoimmune disease. So it's fascinating, and the treatment for all the drugs are normally research-based. So we have what we call clinical practice guidelines that are released, and it'll say usually if they have Crohn's, they're going to go on Humira. If they've got, X, Y, or Z, this is the drug they take, and that's where we start.
And they'll try. That's the other thing, is they may try Humira, and I think I think it's important to note too that to choose one drug over another will come down to a physician that has experience saying, this medication is never covered until you try this other medication first. So they may try Humira, maybe if it's not working, then they go to the next medication. So cost is probably a factor in choice as well, I would think.
So from my perspective, who your physician is in terms of the disease becomes a really important factor, doesn't it?
Yeah. Your physician, your insurance.
So those are all sorts of considerations. You got to think about what insurance is covered, how people can afford it, and all of those other issues.
The severity of the disease would probably be a factor as well.
All right, thanks.
Yeah.
Yeah, great job. Good conversation here. And let's look at those prices. I know you've already looked at them, but Humira, somebody might be on that the rest of their life. Probably will be. $5,400 for 2 doses, and they're going to need a year's worth. So they might get it weekly, they might get it twice a month, depending. And Xeljanz isn't much better, but $4,700 for 60 tablets, and that's usually a month's supply. So again, these dollar amounts add up, and these drugs, like we said, are research proven to actually help the patients. And there's not a whole lot of options out there for the autoimmune community, but these have been proven to work. So we'll talk more about the cost savings later in the presentation. All right, Sarah, let's talk a little bit about dialysis if we can.
The dialysis is something, it's been around for years. This is a treatment used for patients who are in renal failure. So you accomplish what the kidneys do internally in an external manner. You're filtering the blood the way that the kidneys do for healthy people. We're doing this externally for people whose kidneys have failed. It's an expensive process, and it's an old process. And I was just reading an article about how badly, I think it was one you sent me, Mark, about how badly we need to revamp and come up with a new way to treat patients with chronic renal failure because of the cost.
Yeah, and that's an important point there, Sarah, because all these drugs that we list here, none of them are very expensive at all. As a matter of fact, they're pennies on the dollar because they've been around so long. And then treating the patient with the side effects of dialysis, okay, and making sure that they don't have phosphorus building up in their bloodstream, which could kill them. But what I have here is the whole is greater than the sum of the parts, meaning that all of this added up over, most people on retroperitoneal dialysis, which is what Sarah was describing, they got to take it 3 or more days a week, assuming they're not admitted and on continuous renal dialysis. There are some home therapies, but they're not much cheaper than being admitted to do it or going into an outpatient clinic to have it done. And so
Jared, I'm an advisor, and I have a number of clients. How do I help them with this knowledge base? What does it do for me in terms of advising them about making decisions to help their employees be both healthier and have success, and for the company to, frankly, not cost a fortune for their healthcare coverage?
That's a great question, and let's go as far upstream as we can to start that discussion. We can save a lot of renal disease if we can catch essential hypertension early on, if we can catch diabetes early on, and I'm not saying prevent them, but properly treat them earlier in life, and that would help significantly. But if we already have a client, an employee that might be 22% renal ejection fraction or renal function, we can slow down the process of renal failure with the right medications, the right diet, the right fluid amount, and keep them off of any type of dialysis. But if they've made that turn and their kidneys are less than 20%, and they're having negative side effects from the different poisons building up in their blood, then what we can help them do is work with the self-insurers. We can work with the insurance companies, the TPAs and the PBMs, and start working on set costs, what we call reference-based cost, or also evidence-based pricing, and try to get a bundled care price so we don't run out of money at the 40th dialysis treatment. So we can continue to ensure that they get top quality care 3 days a week all year round.
So let me ask you, so if in fact you have somebody's medical record, nobody understands their medical records, they usually never see them, you would be able to give them a risk score, and that would help them. Could you explain how you might do that at Curus?
Absolutely. Yeah, that's one of the many features that we have as a service for our clients. Is Sarah's the one that does most of the intake interviews, and part of that is our risk assessment scoring model, where we'll look to see your current state. We'll also look to see what your genetic factors might be. In other words, what did your mother, father, brother, sister, aunts, uncles, what did they have at this time of your age? What did they die of? And it's an artificial intelligence scoring model that'll put together a high risk score in a certain area, such as renal disease or cancer or heart disease. And then that gives us a leg up in saying, hey, look, this is where we need to focus first with this individual, instead of, something obscure like, colon cancer, if they're not even at risk for it. So that's what that's going to help us do, and really focus in on their true needs.
So the earlier Curus has the medical records of all these employees, the better off those employees would be in terms of the likelihood of their taking proactive action so that they don't get in the situation of facing these heavy drug costs. Is that true?
That is absolutely correct. And not only do we review the records, but we get together our multidisciplinary team where we have PAs, we have medical doctors, we have nurse practitioners, we have a PharmD, that's a doctorate in pharmacy, and we even have a medical legal attorney. So we all look at the records, we talk about what is the best treatment modality for this person, and we come up with a treatment plan. So this really is a detailed process, and you're right, it all starts with the medical records. And how important is that, right?
Sure.
Okay, so great questions, good discussion, everybody. So our last disease state that we want to talk about is hemophilia, and this is one of those it's very rare. I think there's what, like 200,000 or less cases diagnosed in the U.S. However, any self-insured plan knows that it just takes one hemophiliac to sink the entire insurance plan. So what we want to do is talk about hemophilia. Sarah's going to go over it. We're going to talk about the drugs. And then with our innovative solutions, we'll give you an anecdote of exactly one of our cases that helped save over $200,000 a year.
So hemophilia is something we've all heard of. It's a genetic disorder, and it causes someone to be born missing factor VIII, which is a clotting protein. So they have trouble with clotting, blood clotting, and are prone to bleeding, at times severe. And it's an expensive condition, as are all of the conditions we're talking about today. Some of the ways that are used to treat it, there's Hemlibra, there's Eloctate. Eloctate is a factor VIII, but it is one that can be given consistently. It's something you can take daily, so that if you're a hemophiliac and you were to bump your elbow on the table, instead of having to go to the hospital to manage uncontrolled bleeding, you could potentially be able to stay home and then also give yourself just an extra infusion, which we have a member actually with hemophilia who we've helped get onto this regimen, where he's taking the Eloctate daily, which you can see is a significant cost savings, and then just as needed gives himself an injection if he is in a situation where he's prone to more bleeding, if he's bumped himself or if he's having a dental procedure, and he can just give himself that extra injection. Compared to the Hemlibra, which is just, you can see that we don't have to read the numbers out loud to you, how much money you're saving by and you're better managed being on the Eloctate as well.
Yeah, so like Sarah alluded to, this particular member, he was costing the insurance plan and his employer over $300,000 a year because he was on Hemlibra, and he wasn't well managed, and he was admitted several times over a 1 year period. And so you can see that top paragraph, drugs, they can cost more than, for hemophilia, more than $270,000. And that's on average. And that includes 1 to 2 admissions a year. So depending upon the severity, it could definitely climb above 1 million a year. It's not uncommon. So what we do is help better manage the care of this individual. This is what we did. And this individual, unfortunately, with his hemophilia, a lot of times it causes bleeding and necrosis of the joints. Okay. And he was having horrific knee pain and couldn't get a surgery because they couldn't control the bleeding. So once he was switched to Eloctate, it was about a month and a half later, he had a knee replacement. And what's his status today? Do you know?
He's doing great today. He's his knee replacement really well. That was back in the beginning of February. He's been able to resume. He was shortly after the replacement. He was able to resume normal activities. He's connected with an excellent hematology physician that keeps his hemophilia under control, and his joint pain at this point is back to baseline. He still has some occasional pain due to bleeding, minor bleeding into his joints, his large joints, but he's doing very well.
Great. Yeah,
so you played an important role in the process of bringing his costs under control, improving the quality of life.
Yes.
Is that correct?
Absolutely.
Correct.
Great. Any other questions about hemophilia? Okay. So now we're going to get into the part where if you've been on the other webinars, we've talked at great length about innovative solutions, but it's important to go over it again. So I hope we didn't scare anybody with today's presentation, but it's important to highlight how expensive these conditions can be. And that's why the Curus and Curus Health Navigator is specifically focused on the cancer treatment, the autoimmune, immune therapy, dialysis, and hemophilia. And that's going to help save money and help the well-being of the clients. So good idea, fairies here. Innovative solutions. This is some of the things that Curus can do for you and your company and your employers, employees. This isn't the end-all be-all. We have about 30 different other services, but we want to talk about what's the most innovative in our repertoire. So the first one is we help sit down with the individual. We can sit down with their employer if need be, if they would like that. But what we can do is go over their explanation of benefits. So if anybody's ever gotten that looks like a bill, you open it up and it's got some god-awful number on it, a couple $100,000, and then in fine print somewhere in the middle or on the right, it'll say in all caps, "This is not a bill." Okay, I wonder how many people actually write that check and send it in, you know? So what we'll do is we'll walk through that individual. Now, we had a particular client, we still do, who was diagnosed with an awful metastatic cancer. And what they quickly found out, and this is in our last presentation as well, but within the first 3 months after being diagnosed with this particular cancer, they were completely overwhelmed with all the EOBs, their medical bills, their add-on costs, their co-pays, et cetera, et cetera. We finally got that normalized because as you go through, the treatment becomes more standard, hopefully, and then things are easier to review. But so what we did is for 3 months, we sat down with this individual virtually, and we looked at all of her EOBs. We were able to explain to her who did the treatment, where this came from, what they really need to pay. And then we also did, you can see on the second bullet, we did a monthly audit of the medical bills alongside the EOB review. And we were able to save this person close to $12,000 in the first 3 months because there were double bills, triple bills. There were bills from pediatric centers that she never went to that were erroneous. So it's like, okay, don't pay this, pay that one. Let's get this one appealed, you know, or maybe we make a minimum payment this month and see what happens, or rebill insurance. So we can kind of navigate them through that. It's really confusing because obviously, you know, they've been diagnosed with a debilitating disease, could be life-threatening. They're in a family crisis, they're in a mental, personal crisis. And so this is something that we as Curus can do for them and take that burden off their shoulders because they're just emotionally and physically not up for it at that point. So the other thing that we do that's pretty innovative is we'll actually, because I love how Mark says this, it's a great term. Curus is agnostic. We don't work for the insurance companies. We don't work for PBMs. We work for the client. So whoever hired us, we work for their member, okay, the patient. And being a nurse practitioner, I always still call our clients patients, but you get the gist. So we'll call the insurance company, okay, on their behalf, and sometimes with them on the phone. And we'll say, look, this is what we need for this client. This is why. And we'll negotiate with them. And sometimes there's certain larger corporations, insurance companies that actually have advocates for their clients. And we can talk with the advocate, and usually we get that done with 1 or 2 phone calls. So we're not working for the insurance companies. We work for the client, and we will engage on their behalf to anybody we need to get what they need. And so it is an individual care, and we do individualize our services. So some other innovative solutions that are unique to Curus. Was there a question? Okay, sorry. Is one of the things that we've done is we have a proprietary Curus Healthcare Navigator, CHN formulary. And what this is it's all the drugs that are FDA approved, orphan drugs and drugs that are in the pipeline to be approved by the FDA for all of the disease states that we've discussed this summer. And we get updated. We have a monthly update to where we know all the different pricing models for that drug from the time it's released, from the sale from the pharmaceutical company to the supplier, all the way down to what individuals pay per insurance or no insurance at the pharmacy counter. And that goes back to our first webinar. So I encourage you, if you didn't see that one, to go online and check out that webinar. It explains the entire process of why medications are so costly. And so what we can do with this formulary is, since we know the exact prices and the average prices and what Medicare will reimburse prices, we can negotiate with any center or any insurance company about the cost of the medication. So we're currently working with a TPA, trying to get carve-outs for not only these disease states, but also prices on our formulary, and helping drive down those chronic prices that you saw earlier in the presentation. So that's an important
Isn't
feature.
the idea of unique solutions what we're all about? And
Exactly.
as we talk to people, that every person has a different DNA, and every person has a different set of needs. And
That's
part
right.
of the problem that's happening in healthcare today is there's too much cookie cutter approach to each problem. And we've prided ourselves in trying to build these unique, innovative solutions that reflect the needs of an individual in a particular case. If you have a child with renal failure, you treat them very differently than if you have an adult with renal failure.
That's
If you
right.
have a child with an autoimmune disease, it's the same thing. We really focus on each individual and their needs and their family's needs. Because one of the things about all of these delivery systems is that the patients are becoming more and more a cog in the wheel of the delivery system with these large systems that are evolving. And what we try and do is individualize the care so that we're in the corner of our members, the people that we work for. As you mentioned, Jared, before, the idea is we're agnostic. We don't have any biases other than to protect the best interests of people we're taking care of.
That's correct. Absolutely. And you've probably seen the Liberty Mutual commercials. They get funny, but that's what they always brag about, and that's what we brag about is, you only pay for what you need, right? So we're going to put together a care plan, like you said, that's very unique and patient-centric, and we're going to identify the needs of every individual patient and not treat anybody with the same treatment plan, because that's not what we do. So we're very, very specialized in our approach. So with that said, one of the things that Curus has done is we've put together centers of excellence. So what are those? So it's a consortium or a group of different cancer treatment facilities nationwide that they've agreed for evidence-based pricing, which is very innovative. Very few hospitals or clinics will do that now. And so what we're talking about is pricing the treatment exactly right, so it's not a significant upcharge. So what does that mean? These are usually all-inclusive prices. So let's just say somebody comes down with pancreatic cancer. We've talked about this drug before, Lutathera. The drug costs $119,000 per dose, and the individual needs one a month for 8 months. And so we've met with these centers, we've talked to them, and they've agreed that for that particular drug and for those particular patients, which are fairly rare, but even so, with a self-insured plan, you want to know that you're not going to go under for this patient. So they've agreed, everything included per treatment, $65,000. So that's the medication, that's the administration of the medication, that's all their ancillary services, to include if they need a CT scan, if they need massage therapy, pet therapy, acupuncture, they do it all. And that also includes the price for the nursing and the doctor visit and the hotel, because they'll stay on campus. And so if it comes to that and we can save that much money over what they're being charged locally, then we call it medical travel. And so long as we can get the patient down there to one of those centers, the rest is taken care of for that $65K. And that's something we're also working with in the near future. We're hoping to set up the same type of system for neurology, neurosurgery, OBGYN, mental health, etc. So that is an extremely innovative way to do business, and we look forward to helping members out with that. And then I've already alluded to evidence-based pricing, but this is something that has been talked about for a very long time, and hardly anybody wants to use it. And CMS is actually looking to make that a part of their value-based proposition with reimbursement. So we want to stay ahead of this, and basically what we do is we look at just what Mark was saying, the patient's individual needs, what we call comorbidities are, meaning other diseases or chronic diseases, and what's the best treatment for the best price. So, for example, let's just say that let's go back to something maybe autoimmune therapy or whatever. Is Humira the best drug for that patient? Bless you. If it's not, then is that going to do the most good for this patient, or are we just prescribing it because that's number one on the list? Okay, so we'll look at the evidence. We'll look to say, okay, well, if they've got diabetes, congestive heart failure, hypertension, and they've had a history of prostate cancer, maybe that's not the best drug to put them on, and maybe we need to get them to the right specialist to get the correct treatment and the modality. And then once we figure that out, then we can say, all right, well, according to the evidence, the research, this drug shouldn't cost more than X, Y, or Z. And if it does, then that's where Curus comes involved in play, and will help drive down those costs as well. So this is a newer way to do healthcare and business, and I think this is going to be, I know this is going to be the future, and we need to stay ahead of it. So
thanks, Jared. Thanks, Sarah. I think that what's been important is what we're learning today is that the idea of the right kind of medication becomes a critical decision, having the right physician making the decisions and trying to manage the care. But the bottom line is the earlier that we understand what is a person's makeup and what their family history is, the more likely we are to be successful in managing them to a successful conclusion before they have the disease, or if they have the disease, to limit its impact on the quality of their life. I'd like to thank everybody for joining us today. We at Curus would enjoy working with each